good afternoon or evening. I'm Bruce Meyer, and I've been asked to make some introductions. So welcome to the 19th Annual John C. Burnham Lecture. The John C. Burnham Lecture Series in the History of Medicine Science was established in 2000 with gifts from his wife, Marjorie Burnham, to establish an annual lecture in his honor. The Department of History and the Medical Heritage Center of the Health Sciences Library jointly host this annual lecture. Since its inception, 18 individuals have been named as Burnham Lecturers. Our speaker tonight is the 19th Burnham Lecturer. John C. Burnham was a leading international figure in the fields of history, medicine, and science. He wrote more than 80 major scholarly articles, many of which have been reprinted and are considered classics. He also wrote 10 books, edited 4, 2 have won prizes. 1 has been translated into Japanese, and 2 have been translated into Chinese. Professor Burnham taught at Stanford and Claremont College, and he was a Fulbright senior lecturer in Australia at the universities of Melbourne, Tasmania, and New England. He also served as the Tolman Visiting Professor at Bowdoin in 2002 and 3. He was visiting fellow at the Robinson College in the University of Cambridge. He served also as president of the American Association for the History of Medicine and held many other offices in scholarly organizations, both in the United States and abroad. He was the 2014 recipient of the American Association for the History of Medicine Lifetime Achievement Award. Dr. Burnham was a research professor here of history and held a courtesy appointment in the Department of Psychiatry, also here at the university. He was an affiliated scholar of our Medical Heritage Center. We are grateful to his wife Marjorie for establishing this namesake lecture and will keep his namesake alive at The Ohio State University and beyond. At this time, I'd like to introduce Professor Scott Levi, Chair of the Department of History here at OSU, who will introduce our speaker. Thanks, Scott.
Thank you, Dr. Meyer. It's my great pleasure to be here today to help introduce our 2023 John C. Burnham Lecture in the History of Science and Medicine. Unfortunately, Marjorie Burnham can't be here with us today, but we would like to extend our deepest gratitude to the Burnham family for their generosity, which has enabled us to endow the John C. Burnham Lecture Series now in its 19th year. Now, it's my privilege to introduce our distinguished speaker this year, Dr. Johanna Schoen. I hope I got that right. That was great. Thank you very much. Professor of History at Rutgers University with an affiliation at the Institute for Health, Healthcare Policy, and Aging Research. Professor Schoen is a specialist in the history of women, reproductive rights, and medicine more generally. Johanna is with us in the United States today because as a 17-year-old in Hamburg, Germany, she happened to see a note on a bulletin board advertising a high school exchange program. As a result, she left Germany to spend a year in Motley, Minnesota. Now, I grew up in Iowa, just south of the Minnesota border. I'd never heard of Motley. I was going to say smack between St. Cloud and Bemidji. That's right. But it's a very small town of just a few hundred people. I was there that her interest in American history was first sparked. She then returned to Hamburg for her undergraduate studies, where she earned a degree in history with minors in economics and political science. She returned to the United States for her graduate studies, earning a Ph.D. in American history at the University of North Carolina, Chapel Hill. Professor Schoen is no stranger to Ohio, having worked in the 1990s as a visiting assistant professor at the University of Akron and instructor at Bowling Green State University. She later moved on to work as assistant and associate professor at my own undergraduate alma mater, the University of Iowa's Departments of History and Women's Studies from 1999 to 2011, and then she continued on to the Department of History at Rutgers. Professor Schoen's professional career has been highly distinguished. Among her many accolades, she's been awarded research grants from Fulbright and the National Endowment for the Humanities, and she was twice awarded the Social Science Research Council's Sexuality Research Fellowship. Johanna is the author of 2 books. Her first, titled Choice and Coercion, Birth Control, Sterilization, and Abortion in Public Health and Welfare in the 20th Century, is a deep analysis of the roles that birth control, sterilization, and abortion played in public health and welfare policies between the 1920s and 1970s. Her second book, Abortion After Roe, won the 2017 William H. Welch Medal for the best book in the history of medicine, awarded by the American Association for the History of Medicine. Professor Schoen also edited the 2022 anthology, Abortion Care as Moral Work, which brings together the diverse voices of abortion providers, abortion counselors, clinic owners, neonatologists, bioethicists, and historians. And this evening, we are very fortunate to hear about Professor Schoen's research for her upcoming book, Life and Death in the Nursery, which will focus on the history and bioethics of neonatal intensive care units. We are honored to have Professor Johanna Schoen with us here today to deliver her talk, Life and Death in the Nursery, the Establishment of Neonatal Intensive Care Units and Debates in Bioethics. Please join me in welcoming Professor Johanna Schoen as the 2023 John C. Burnham Memorial Lecturer in the History of Medicine and Science.
Thank you so much. I can't tell you what a pleasure it is to be here. And I want to thank both Scott for the wonderful invitation to come and deliver this lecture, and Amanda for all the work she did in terms of anything else that was related to it. And those amazing appetizers. You guys have the best appetizers in the world. Before I get into this lecture, I want to say 2 things about how I ended up with this topic. The first one being is that as I was finishing the book, and then in the aftermath on the book on the history of abortion after Roe, I was really interested in the way in which medical professionals, abortion providers, and people who work in abortion care, as well as women and their partners, make medical ethics argument in defense of abortion care. And the kind of medical ethical arguments to make a decision to end a life, particularly when we talk about late abortion care, are very, very similar to the kind of arguments that people make as they try to deliberate when to provide care in the neonatal intensive care units and when to withdraw care or when not to give any care at all. So as I was diving into this topic, I just was really struck by the similarities, and they're kind of driving this project forward. But the other thing that really interests me about it, one of the things I do when I don't do history is I volunteer at Memorial Sloan Kettering Cancer Center, and I started volunteering there in 2017 after a partner I had, whom I was taking care of while she had endometrial cancer, died. And after she had died, I basically joined the Patient and Family Advisory Council, of which I am currently the co-chair, which is taking way too much time, but the term is almost over. But I was really interested, to join a hospital and to try to improve patient care from inside the institution and what that means and how we do it. And partly because of my personal experience of having a partner who then died, I was also really interested in the question of how do you make a determination of when to stop treatment, and how do you have a conversation about the end of life and the kind of decisions that you have to make. And so I feel a little bit like, and then what I also discovered, which you will partly hear tonight, is there are all these parents who become active and who build the parent interest movement for NICU. And so I feel a little bit like my personal activism, which has never laid in the issues that I directly researched. Like I was never active in terms of abortion care. That was just too much to do that intellectually and then to also do it as activism. But the cancer area, it kind of brings things together that I didn't realize before. The other thing I wanted to say is that as I get into this talk, I will use some language that is today considered somewhat offensive, and I partly do so because I'm trying to use the language that was appropriate at the time and that clinicians used at the time to really get an appropriate sense of the discourse of the 1960s and 70s. So when you hear terms that are not in quotes, but I still use that language, that is the reason why. And one note of caution as we get into the second part of the paper, some of the details are actually quite gruesome. Those who know me know that I call a spade, so that's partly why. So thank you for coming, and I will just start. In 1973, Raymond S. Duff and A.G.M. Campbell, two pediatricians at Yale New Haven Hospital, published an article in the New England Journal of Medicine assessing how more than a decade of neonatology had benefited infants and their parents. The authors observed that in hospitals with intensive care units, neonatal mortality rates had fallen by half compared to hospitals without such units. But while some survivors of these units were healthy, others continued to suffer. Severely handicapped by a myriad of congenital malformations that in previous times would have resulted in early death, the authors noted in the new treatment options raised increasing concern about the quality of life for these severely impaired survivors and their families. The authors analyzed the medical and ethical issues physicians and families were facing as new medical technologies prolonged the life of severely ill infants and raised questions about what neonatology had achieved, what it couldn't do, and what it shouldn't do. Duff and Campbell offered a detailed analysis of infants that had died in Yale's special care nursery. They were careful to differentiate cases in which infants had died from pathologic conditions in spite of treatments, category 1, from cases in which infants had died because clinicians had decided to discontinue treatment, category 2. A careful analysis of the 256 infants who had died from pathologic conditions despite treatment indicated that the mean length of life for these infants had been just under 5 days. 50% had died within the first 2 days of life, although one had lived for more than 2 months. 66% had died as a result of respiratory problems or complications associated with extreme prematurity, a birth weight under 1,000 grams, and another 22% had succumbed to congenital heart disease and other anomalies. In contrast, the 43 infants in category 2 had suffered from severe impairments, usually resulting from congenital disorders. Because these infants had died after pediatricians had decided to discontinue treatment, since the infant's condition did not improve despite treatment, the infant's mean length of life was longer, 7.5 days compared to 4.8 days for infants in category 1. While 12% had died within 48 hours, pediatricians spared no efforts in their treatment of infants in category 2. Duff and Campbell reported that clinicians labored almost 2 months over 8 infants in hopes that the infant's condition would eventually improve. Dependent on oxygen, digoxin, and diuretics, the infants had been treated for idiopathic respiratory distress syndrome with high oxygen concentrations and positive pressure ventilation. Finally, however, clinicians had given up as the condition of the infants did not improve or worsened. Deciding to stop treatment after such prolonged attempts to save an infant could be distressing to all involved. Duff and Campbell described the case of one infant who had been born with immature lungs and after 5 months of treatment suffered from chronic pulmonary disease and was dependent on a respirator. Even on the respirator, he had difficulty breathing and was of bluish discoloration due to a lack of oxygen. In addition, the infant suffered from an enlargement of the right side of the heart as a result of the lung disease. The family had endured high expenses, The hospital bill exceeded $15,000, more than $207,000 today. The siblings were developing behavioral problems, and the marriage was under strain. The nurses, parents, and physicians considered it cruel to continue and yet difficult to stop. All were attached to this child whose life they had tried so hard to make worthwhile. Such decisions, the physicians made clear, were agonizing for all involved. When physicians and parents finally decided to stop oxygen supplementation for the infant, he died in about 3 hours. 2 questions stood at the center of Duff and Campbell's considerations: how to decide which infants to treat and which not to treat, and how to decide how much input parents should have in treatment decisions. Established in the fall of 1960, the Yale Newborn Special Care Nursery was the first such unit in the country to offer sick infants and their parents a dazzling array of new technologies in one space. Its founder, Louis Gluck, born and raised in Newark, New Jersey, graduated in 1952 from the University of Chicago Medical School. After completing a rotating internship in 1953, he joined a general group practice in Harlan County, Kentucky, to pay off his medical school debts. Gluck recalled his year in Harlan County as harrowing. His patients were minors dying of cancer and silicosis, their children sick and neglected. Worse, he and his colleagues began to receive death threats after the medical group went to court on behalf of the minors and won 3 cases against the coal companies. Gluck left to spend 2 years in solo practice in Lakewood, New Jersey. In 1956, he joined Babies Hospital at Columbia Presbyterian Medical Center in New York City as a pediatric resident and fetal life fellow. There, he became the first fellow to William A. Silverman, an early giant in the field of neonatology. Assessing the state of newborn care in the late 1950s, Gluck realized that pediatricians were failing critically ill newborns. For more than 40 years, preemie nurseries had hewn to the pattern established by the French professor of obstetric Pierre Boudin and Julius Hess, an early prominent Chicago pediatrician whose 1935 development of the Hess oxygen bed ignited a wave of enthusiasm for oxygen therapy. Highly skilled nurses, such as those trained by Hess' chief nurse, Evelyn Lundeen, had primary control of the units. Doctors were essentially outsiders. The tiny patients were stored in warm glass incubators and handled as little as possible. Americans approached the care of preemies in the post-war years with an aggressive optimism that reflected the national faith in science and technology. The country, with support from the government, began to direct its attention and considerable resources to deal with medical issues considered of national importance, among them the high infant mortality rate. As historians have pointed out, and William Silverman himself sharply criticized by the 1950s, clinicians jumped from consideration of reasonable theory to application in everyday practice. But the use of untested treatments and new medical technologies had produced catastrophic results. In the 1940s and 50s, it became increasingly fashionable, for instance, to give large amounts of oxygen to preemies who, as a result of their premature lungs, had developed respiratory distress syndrome. But this had led to an epidemic of infant blindness, for instance. It wasn't until 1954 that the result of a national cooperative study among 18 hospitals indicated that the cause of blindness was too much oxygen. Clinicians knew how to take care of premature babies who were relatively well, but didn't know how to treat severely ill newborns. The latter wound up in isolation on obstetrical or pediatric wards. Infant mortality rates among critically ill infants were high, and Gluck concluded that it was time to bring them into one space to organize their care centrally. It is difficult to overstate the structural hurdles that clinicians had to overcome to establish centralized neonatal intensive care units. Intensive care across the country was isolated and fragmented, frequently consisting of a series of tiny sequestered cubicles or an isolated area filled with bulky electronic equipment. In addition, hospitals were subject to waves of staph infections, and state laws required that patients be isolated within their respective wards. You couldn't mix newborns and preemies, Gluck remembered. You couldn't mix medicals and surgicals. You couldn't mix outborns and inborns. And if there was a question of an infection, you had to send them to East Jerusalem or someplace in order to get them out of sight of anybody else. A careful review of the literature led Gluck and his colleagues to realize that the infections were not, as assumed, airborne, but spread because people failed to wash their hands and picked their noses. Little has changed. In 1959, after completion of his residency and fellowship, Gluck moved to the Stanford University School of Medicine, where he became director of newborn services at Palo Alto Hospital. There, he set up a controlled study testing his theories of infection. Gluck and his colleagues began to wash 1 out of every 3 babies in the delivery room with a disinfectant, thereby virtually eradicating staphylococcal colonization of the newborn. In 1960, Gluck moved from Stanford to the Yale New Haven Medical Center to expand the existing 9-incubator premature nursery into a newborn special care unit. After implementing the same infection control measures he had tested at Stanford, he slowly scaled up the number of infants admitted. Initially, he explained, we admitted only sick infants, premature or full-term, born at our own medical center. After a few months, we accepted high-risk newborns from other hospitals, then readmissions, and finally we extended our services to all neonates with special surgical and medical problems, including infants with infectious diseases. During this period, we took thousands of cultures from infants and personnel at the unit and worked out the hand washing, gown cleaning, and skin and cord care techniques necessary to prevent cross-infection. These basic techniques were then instituted in every nursery at the medical center. Following this 14-month period, the hospital officially opened the Newborn Special Care Unit in January of 1962. The new unit centralized the care of infants who had previously been scattered across the hospital, where they had been cared for by nurses with no experience in infant care. Now, premature infants as well as non-premature babies who needed special management were moved into one area under the care of nurses and physicians specializing in the care of premature and sick newborns. Later that year, the hospital converted an adjacent obstetrical ward into a special care area, thereby adding another 13 cribs to the new unit. But the biggest expansion push began after December 1964, when a donation of $500,000 from Mrs. Eleanor Naylor Dana, together with funds from other sources, allowed for the establishment of a unit large enough to house up to 40 infants with special problems. Carefully planned to incorporate the latest designs, the new unit was a marvel of modern medical technology. It featured 1 large and 3 smaller rooms built around a central nursing station. To increase efficiency, the design team reduced the space between the 40 isolates from between 30 and 50 feet to 20 feet by placing all the equipment for each isolate in the ceiling above. Flexible tubes for oxygen, compressed air, suction, and multiple electrical outlets hung down from the ceiling, allowing nurses and physicians to instantaneously attach respirators, monitoring devices, and infusion pumps to the infants below. In addition, clinicians had access to a variety of standard and cardiopulmonary monitoring and resuscitation instruments, including a volume-controlled respirator, a portable unit to determine blood gases, cardiac monitors, apnea alarms, as well as an open-air radiant heater crib, a prototype made by Air Shields Company, which permitted clinicians to perform procedures without worrying that infants would develop hypothermia. windowless. The unit was located in the middle of the building. The overhead lighting and the constant hum and beeping of the medical equipment made the space loud, noisy, and bright. It reminded me of the movie Coma, one of the nurses remembered. The bodies were all suspended and they were maintained by machines. This is why it's always good to interview nurses. The nurses also told me that the nurses actually couldn't get at the equipment hanging from the ceiling. It was so high that only the physicians could get at it. The transition of pre-nursery to NICU, journalist Jeff Lyon observed in Playing God in the Nursery, was inspired by parallel developments in adult medicine. The first adult intensive care unit was established in 1959 by Dr. Max Harry Wheel at Los Angeles County General Hospital. It was followed in 1962 by the first coronary care unit, founded at Bethany Hospital in Kansas City. Pediatricians concluded that the concept would also work for their infant patients. The Yale New Haven Special Care Nursery emerged alongside NICUs and other medical centers in the US. In Nashville, neonatologist Mildred Stahlman established a neonatal intensive care unit at the Vanderbilt University Medical Center in 1961. Funding from the National Institute of Health to study respiratory distress syndrome allowed Stahlman to establish and equip the new facility. In other medical centers, too, physicians began to experiment with the idea of neonatal intensive care units. The Hospital for Sick Children in Toronto, Royal Victoria Hospital in Montreal, University Hospital and Hammersmith Hospital in London, Stanford University Hospital, Boston Children's Hospital, the University of Pennsylvania, the University of California at San Francisco, and Johns Hopkins University all established NICUs in the early 1960s. With the establishment of NICUs, the treatment of premature and critically ill newborns changed from a philosophy of handling the infants as little as possible to one of aggressive treatment. Major changes in the clinical care of premature infants in the 1960s meant that clinicians could now keep their patients alive. The provision of assisted ventilation for continuous respiratory support in the mid-1960s and the development and administration of surfactant to premature infants to treat respiratory distress syndrome revolutionized the field of neonatal medicine, while the introduction of IV feeding and the development of microinfusion pumps allowed for the feeding of extremely preterm infants, and by the end of the decade, high-caloric IV preparation were better able to meet their nutritional needs. The time had come to concentrate all these treatment options in a NICU. The establishment of clinical centers devoted to the care of premature and sick infants increased the number of patients as well as the clinical problems with which infants presented. But the ability to now treat severely ill infants for whom treatment had not been available earlier also led to disagreement between physicians or between physicians and parents over appropriate treatment options. This was especially the case in situations where clinicians and parents were unexpectedly confronted with a child with congenital anomalies, such as infants born with trisomy 21, Down syndrome, with duodenal atresia, an intestinal obstruction, or infants born with myelomeningocele, MMC, the most common and most severe form of spina bifida, a congenital nervous system defect. The establishment of NICUs and special care nurseries allowed clinicians for the first time to systematically address the surgical needs of these infants and, in the course of the next 2 decades, changed the clinical understanding of what could and should be done for them. Duodenal atresia is a condition in which the first part of the small bowel, the duodenum, is blocked, preventing food and fluids to pass from the stomach to the intestine. While the blockage is easily corrected by surgery, infants who do not receive the surgery die of starvation and dehydration. Since a third of infants with duodenal atresia have trisomy 21, the classic textbook, The Surgery of Infancy and Childhood had advised surgeons in the 1950s to carefully evaluate all infants with duodenal atresia and to forego corrective surgery if infants showed signs of trisomy 21. Similarly, before the 1950s, the prognosis of infants with myelomeningocele, which involves varying degrees of leg paralysis and bladder and bowel impairment, was poor. Approximately 80% of children with MMC have hydrocephalus, which can result in cognitive impairment and blindness. Most died in the first few months of life of meningitis or as a result of hydrocephalus. Because of the complex medical needs of these infants, as well as the social stigma and isolation of giving birth to a child with a severe disability, children with MMC, or trisomy 21, were until the 1950s frequently raised in institutions. Indeed, considering the outcomes for these infants extremely poor, clinicians frequently advised parents that infants with trisomy 21 and duodenal atresia, as well as infants with myelomeningocele, be left to die. But three things changed in the 1960s. First, the birth of clinical genetics in the 1950s and 60s led to an understanding of genetic diseases. Second, a number of exposés in the 1960s highlighted terrible conditions in mental institutions and residential schools, leading activists to lobby for deinstitutionalization. After legislation in 1963 made mental retardation a federal health policy issue, the federal government adopted an approach to reduce institutional population and offer community support. Parents, too, began to voice concerns about institutionalization, and some began to establish advocacy groups that moved children with disabilities into the mainstream. Third, advances in therapies and refinement in surgical techniques contributed to the survival and higher functioning of infants with spina bifida and other health problems. By the early 1960s, the development of antibiotics to treat meningitis and of shunts to alleviate hydrocephalus allowed physicians to aggressively treat infants with MMC. Most clinicians began to follow a policy in which infants with MMC were operated on 12 to 48 hours after birth. Survival rates for these infants rose significantly, and when 3 surgeons at Children's Hospital in Sheffield, England, reviewed the results of 526 children born between 1955 and 1962 and treated for MMC, they strongly endorsed aggressive treatment for MMC infants. And as the 1960s progressed, clinicians' attitudes for infants with trisomy 21 also began to shift. By the early 1960s, the surgical correction of duodenal atresia was well established. Moreover, neonatologists found over the course of the 1960s that they were able to save infants with other medical problems who would have died a decade earlier. These changes notwithstanding, many parents continue to be wary of raising a child with severe disabilities. The rubella epidemic and the thalidomide scare in the 1960s heightened Americans' concern about bringing home an infant with a disability. Faced with caring for a severely disabled and/or intellectually impaired child, families confronted significant caregiving burdens and expenses. They struggled with social shame and isolation at a time when raising a disabled child at home was still an intensely private experience. As one neonatologist remembered, parents dreaded having retarded children. When in 1963, pediatricians at Johns Hopkins University encountered an infant born prematurely with trisomy 21 and duodenal atresia, a debate about the treatment of the infant ensued. Worried about the impact that a child with severe disabilities would have on their family, including the 3- and 5-year-old siblings at home, the parents refused to sign permission for the surgery that would have corrected the duodenal atresia. The infant died 6 days later. By the early 1970s, medical files at Johns Hopkins University Hospital suggested that the 1963 infant had not been alone. Other infants born with trisomy 21 and duodenal atresia too had been left untreated and had died. Indeed, it is likely that this happened in hospitals around the country. When, in 1971, Robert E. Cook, pediatrician-in-chief and chairman of the Department of Pediatrics, learned of another infant with trisomy 21 and duodenal atresia whose parents had decided against surgery, he tried unsuccessfully to intervene. The infant died after 13 days. Dissatisfied with his faculty, some of whom had supported the parents' decision, Cook turned to the Joseph P. Kennedy Jr. Foundation, which was preparing an international symposium on human rights, retardation, and research, and suggested the creation of a brief documentary dramatizing the 1963 and 1971 cases to screen at the opening of the symposium. The resulting film, Who Shall Survive?, one of the choices on our conscience, premiered in October of 1971. Over 9 minutes and 15 seconds, it traces the delivery of baby Doe, his diagnosis with trisomy 21 and duodenal atresia, the parents' decision not to consent to surgery, the sign on his crib indicating that he should receive nothing by mouth, and the wait until his death in the documentary 15 days later. The film highlighted the moral distress of the staff as the baby slowly starved to death. One could not come away from watching the film without the impression that what had happened here was wrong. More than any case up to that time, Who Shall Survive brought the issues of end-of-life decisions involving infants with disabilities out of the back rooms of the hospitals and to international attention. Over the course of the 1970s, clinicians debated the ethics of non-treatment and the clinical details surrounding these decisions. Duff and Campbell were not alone in their concern that the success of neonatology over the past decade had led to the survival of severely compromised infants who would have died a decade earlier. To focus on myelomeningocele as an example, by the early 1970s, John Lorber, one of the original authors of the 1967 recommendations to aggressively treat infants with MMC, had changed his mind. After following treated MMC survivors for 7 to 12 years, Lorber judged the human costs to patients' families and the communities too high. While intensive treatment of spina bifida cystica in recent years has resulted in a much increased survival rate, he noted in 1971, there are large numbers who are so severely handicapped at birth that those who survive are bound to suffer from a combination of major physical defects. Instead, Lorber now sought to develop criteria that would allow clinicians to select when to treat and when not to treat. If we wish to spare children and their families prolonged suffering and to give better attention to those who are more likely to benefit from total care, he argued, we may have to select suitable cases for intensive treatment and others for no treatment. Through the 1970s and into the 1980s, medical centers in the United States debated Lorber's new recommendations. Seeking to gain certainty in an uncertain environment, they collected mortality rates of infants selected for non-treatment, discussed the condition of those who survived despite non-treatment, and tried to further refine selection criteria for non-treatment. Clinicians bemoaned the emotional suffering and chronic grief that attended the birth and survival of a deformed, retarded child, and urged careful evaluation to identify hopeless, burdensome cases before initiating expensive and life-prolonging treatment. The emotional and physical pain that we cause child patients to suffer, they concluded, must be justifiable in terms of some reasonable hope for a future happy social adjustment. But clinicians lacked a unified understanding of the meaning of future happy social adjustment. While Lorber and others had sought to ensure that infants would be able to become productive citizens, Others warned against such utilitarian views. The problem remained further confounding since untreated infants who were expected to die did not necessarily die. Indeed, physicians across the country expressed bafflement at the survival of infants selected for non-treatment. After following 75 infants at the Children's Hospital of Michigan for 18 months, for instance, a team of Detroit physicians reported an unexpectedly low mortality rate. Notwithstanding the decision not to treat, most of the infants had received some treatment during the 18 months, indicating that not all clinicians and nursing staff who cared for the infants agreed on the criteria and protocol for non-treatment. In the end, the survival rate for non-treated infants strongly motivated centers to offer care to all infants with MMC. As Yale neonatologist Ian Gross noted about the experience with MMC infants at Yale, they weren't dying. They were just ending up in terrible shape. So we changed our policy. But as Duff and Campbell's article suggested, the problem in neonatology was not really undertreatment, but overtreatment. The ordeal of Andrew Stinson is a case in point. Andrew was born in December 17, 1976 at a community hospital in Bethlehem, Pennsylvania. At 800 grams and a gestational age of 24.5 weeks, he was not expected to survive, and his parents, Peggy and Robert, asked the medical staff at community hospital that no heroic efforts be made to extend his life. But a week after his birth, Andrew was transferred to the NICU at Children's Hospital in Philadelphia, a tertiary care hospital where he was placed on a respirator. Over the following 6 months, he became, in the words of his parents, hopelessly entrapped in an intensive care unit where the machinery was more sophisticated than the code of law and ethics governing its use. He remained dependent on the respirator until he was finally allowed to die 6 months later. Andrew developed a range of complications as a result of the treatments he received trying to keep him alive. Problems supporting his underdeveloped lungs and providing appropriate nourishment for an extremely premature infant characterized his medical trajectory. His inability to properly breathe on his own led his physicians at Children's to place him on the respirator, as a result of which he developed bronchopulmonary dysplasia, neonatal chronic lung disease, as well as retrolental fibroplasia, an eye disease frequently leading to blindness. The chronic lung problems in turn led to a slowing of Andrew's heart rate and a lack of oxygen in his blood. Physicians' attempts to artificially nourish Andrew were nearly as unsuccessful as their attempt to breathe for him. His unmet nutritional needs, in particular his lack of minerals, led to multiple bone fractures as well as the development of a cleft palate. As Andrew's lungs became irreparably diseased, he developed high blood pressure and began to have seizures. When, on June 10th, Andrew dislodged the tube connecting him to the respirator, CHOP's physicians decided not to reconnect him. He finally died on June 14, 1977. As his parents sarcastically noted, he was in effect saved by the respirator to die 5 long, painful, and expensive months later of the respirator side effects. Devastated and furious, Peggy and Robert Stinson wrote a letter to CHOP's administrators and personnel sharply criticizing the aggressive treatment of Andrew. The story of Andrew's short, cruel, institutionalized life, they warned, is a case study in the limits and excesses of modern medicine. In 1979, they published a book, The Long Dying of Baby Andrew, about the ordeal. In addition, they published an abridged version of their letter to the hospital in Atlantic Monthly and in 1981 in the Journal of Medical Ethics. Indeed, Andrew Stinson's case was far from exceptional. Parents across the country found that neonatologists ignored their wishes to allow their severely ill infants to die, instead resorting to coercion, threats, and court orders to treat the infants, only to have them die months or even years after gruesome medical ordeals. The Stinson's complaints were followed a couple years later by similar charges from a California couple, Sue and John West, who in October 1980 gave birth to their infant son, Brian. Brian was diagnosed with trisomy 21, esophageal atresia, which means a missing esophagus, and a heart murmur. The attending physician described how the particular combination of Brian's defects were far more serious than either one of them would have been alone. His missing esophagus could be surgically reconstructed, but Brian would never be able to swallow normally and would constantly be in danger of choking on his food. Since trisomy 21 was associated with poor muscle tone, this further increased Brian's chances of choking. In addition, stomach acids would back up into his reconstructed esophagus, and since children with trisomy 21 are also overly susceptible to upper respiratory infections, without a properly functioning esophagus to drain normal secretions to the stomach, these fluids could back up, enter the lungs, and cause pneumonia. Finally, physical therapists warned that the reduced mental capacity of children with trisomy 21 might defeat the therapeutic process required to learn how to use the new esophagus, and that Brian's frequent hospitalizations and surgical interventions would mean that attempts at early intervention and stimulation, so crucial for children with trisomy 21, would be frustrated, indeed, might significantly set Brian back. Doubting that the long-range outcome for Brian would be good, the Wests refused to authorize the surgical repair of Brian's esophagus. The decision, John West remembers, was based on love and on the golden rule. Had they been in Brian's place, neither he nor his wife would have wanted to be kept alive. The hospital, however, disagreed with the West's refusal to consent to Brian's surgery and asked the state to bring charges under the state's child abuse laws against the Wests. The Wests were charged with willful neglect, and Brian was removed from their custody and placed under the guardianship of the state. As Susan West recalled, "We watched helplessly as our baby endured multiple surgeries and a host of chronic, painful maladies. Brian spent the initial months of his life attached to a nasal suction machine and was fed by a hose through a hole in his stomach. Infections became chronic. Reconstructive surgery on the esophagus was performed in 2 stages when he was a little over a year old. The process can only be described as hell for him. The wounds failed to heal properly, stomach acid backed up continuously, causing such pain and irritation that it became necessary to restrain the baby's hands and feet by tying them to the 4 corners of the crib. His new esophagus was never functional, and he became caught in a perpetual pilgrimage from nursing home to hospital and back again. Shortly after his 2nd birthday in October of 1982, another infection of unknown origin sent him to the hospital once again. While there, he went into respiratory shock and was placed unconscious on a respirator. When he stabilized, he was severely brain damaged, blind, bleeding internally, experiencing intermittent kidney failure, and had an overwhelming infection throughout his body. On December 21, 1982, at 26 months of age and weighing only 14 pounds, Brian James West finally died. 5 days later, John and Susan West appeared on CBS's 60 Minutes to talk about their experience. Parents were not only upset at their inability to prevent aggressive treatment of their severely ill infants, they also protested the conditions under which their infants were being treated. When in the mid-1980s, Jill Lawson learned that her premature son, Jeffrey, had been awake throughout major surgery at Children's Hospital National Medical Center in Washington, D.C., the anesthesiologist had paralyzed Jeffrey with Pavulon, a curare drug that left him unable to move but totally conscious, Lawson raised alarm. Together with NICU parent turned health advocate Helen Harrison, Lawson and Harrison protested this practice in letters to the editor of Birth. 10 years ago, Harrison noted, our prematurely born son, Edward, was shunted for hydrocephalus while paralyzed with Curie. Although he could not move, cry, or react in any way, he could see, hear, and feel, as large incisions were cut in his scalp, neck, and abdomen, as a hole was drilled in his skull, as a tube was inserted into the center of his brain, then pushed down under the skin of his neck, chest, and abdomen, and implanted deep in his abdominal cavity. We were told that Edward might die or become brain damaged without the operation, and that anesthesia might kill him. Besides, the doctors assured us these babies don't really feel pain. I suspect then, and now know, that this is just not true. To this day, our severely retarded son will allow no one to touch his head, neck, or abdomen. Even heavily tranquilized, he reacts to the simplest medical procedures or the mere sight of the hospital with violent trembling, profuse sweating, screaming, struggling, and vomiting. At a 1985 National Conference of Parents of Premature and High-Risk Infants, mothers and fathers discussed a wide array of painful medical procedures their children had been subjected to. Major surgery, chest tube insertions, cut downs, all performed without painkillers, gangrene and amputations from infiltrated IVs, bones broken during chest physiotherapy, skin pulled off with adhesive tape, burns from the monitors. Added to that were the 24-hour-a-day bombardment with bright light and loud noises and numerous iatrogenic afflictions from improperly evaluated therapies. If this were going on in any other setting, one mother exclaimed, it would be called torture. Parents tried a variety of avenues to protest these practices. For the most part, however, their complaints fell on deaf ears. One mother refused to sign the consent form for her daughter's surgery after realizing that no anesthesia would be used. The operation was performed anyway, Harrison reported, and the mother was reported to local authorities as an abusive parent. Lawson complained about her son Jeffrey's ordeal to the Washington, D.C. Medical Society, the Washington, D.C. Commission on Licensure to Practice the Healing Arts, the Washington, D.C. Child Protective Services Agency, none of whom were willing to intervene since the anesthesiologist had apparently followed the standards of practice. The American Board of Anesthesiology told Lawson that such cases were none of their business, and when Lawson called the federal hotline set up in 1982 after President Ronald Reagan passed so-called baby doe regulation, whose avowed purpose it was to prevent inhumane medical practices, the staff at the hotline were not interested once they learned that Jeffrey had in the meantime died. Referring to the frequent charges that parents who wanted to prevent aggressive treatment of their severely ill infants were abusing their infants, Harrison charged that the real abuse was perpetrated by medical professionals. In the past 2 decades, a great deal has been written about parents as abusers of their premature babies. The time has now come for a long, hard look at the medical abuse of newborns, especially of those babies unfortunate enough to be born prematurely. What were neonatologists and pediatric surgeons thinking when they aggressively treated these infants and failed to use analgesics and anesthesia? To start with the latter, many doctors believed that preemies did not feel pain. I don't know if I have a body of knowledge that tells me if they don't perceive or feel pain, or if there are differences from older children and adults. Dr. Willis McGill, chief of anesthesiology at Children's Hospital National Medical Center, defended the treatment of Jeffrey Lawson. While McGill admitted that some neurologists described a newborn's response to stimulus as withdrawing in pain, he suggested that this could be a simple reflex. The development of anesthesia to neonates was a recent development, McGill argued, and some infants were too fragile to tolerate anesthesia. It doesn't do any good to have a dead patient who doesn't feel pain, he quipped. Lawson also suggested that anesthesiologists followed the standards of practice when they failed to give anesthesia, and that some surgeons were unaware that they were operating on an infant without anesthesia. This apparently included Jeffrey's surgeon, who had assured her beforehand that Jeffrey would receive anesthesia. After the Washington Post reported on the experience of Jeffrey and Jill Lawson in August of 1986, the American Society of Anesthesiologists and the American Academy of Pediatrics each produced statements on the appropriate use of analgesia in neonates, and by the late 1980s, clinicians embarked on a systematic investigation of neonatal pain responses. A number of factors determined clinicians' attitude about aggressive treatment. Clinicians who had trained in the 1940s and 50s prior to the advances that characterized neonatology in the 1960s and 70s were taught not to back off. But clinicians also noted that aggressive treatment in the 1950s meant something different than aggressive treatment 2 or 3 decades later. As one neonatologist noted about the 1940s through 1960s, you couldn't keep a dying or dead body going for hours, for days, weeks, maybe a month. As you get better at what you do and as you're able to prolong dying, then I think you've got to start to look at what it is you're doing. In addition, clinicians often became caught up in the excitement of addressing clinical problems in the present, while losing sight of the fact that parents worried about the long-term future. When William Silverman recalled his enthusiasm as he rescued a premature infant no one expected to survive, the infant did well, and I felt like a hero. For 3 months, the survival of this infant was a sensation. I realized only later that the parents were horrified. Here was this young whippersnapper not only keeping this baby alive, but using untested methods to do so. I could not understand why they didn't see this as a glorious adventure. They were looking into the future, and I was looking at the present, and it was a very exciting present. Finally, especially after the rise of the pro-life movement and the passage of the Baby Doe legislation under the Reagan administration, the discussion over treatment of severely ill neonates became distorted by pro-life politics. Worried about whistleblowers and lawsuits, many neonatologists began to practice defensive medicine. Others tied their support for aggressive treatment to their own pro-life beliefs. See Everett Koop, for instance, who built the pediatric surgery service at CHOPS, the hospital where Andrew Stinson had been treated, was strongly pro-life and imparted his philosophy on his service. Clinicians shied away from an open discussion about the suffering infants might endure as a result of treatment, foreclosing a consideration whether allowing an infant to die might be more humane than attempting or continuing treatment. Instead, they trivialized and oversimplified the medical problems of infants and refused to acknowledge the broad range of functionality and further health complications an infant and their families might face in the future. But as parents began to protest the treatment of their infants, some neonatologists sided with the parents and offered them an avenue to reach the larger community of neonatologists by publishing their editorials and letters to the editors in medical journals. Helen Harrison, who in 1983 published the Premature Baby book to help other parents deal with the birth of a premature infant, gained the ear of both NICU parents and clinicians. She and Jill Lawson found a strong ally in John W. Scanlon, director of neonatology at Columbia Hospital for Women, as well as the editor of the journal Birth, who published their letters to the editor protesting the performance of medical procedures without anesthesia. Indeed, Scanlon, who had referred Jeffrey Lawson for surgery to Children's Hospital National Medical Center, wrote a scathing editorial entitled Barbarism in Perinatal Press, in which he took his colleague to task. Commenting on McGill's claim that little babies don't feel or remember pain, Scanlon noted, "The physician's ignorant comment was such a shocking revelation that I inquired among friends and colleagues whether they had ever heard anything so astounding before. To my utter amazement, several nurses and physicians indicated that yes, they had witnessed some rapidly performed neonatal surgical procedures done without the benefit of anesthesia. Unless comatose, all babies respond to noxious stimuli and possess a variety of neurobehavioral mechanisms to deal with them. This suggests that babies not only feel pain, but that they retain memory about unpleasant adversive events. Veterinarians anesthetize small animals for surgical procedures. The human newborn should at least be afforded a similar consideration. In addition, the executive editor of Perinatal Press urged his colleagues to personally assess how patients they had referred to colleagues were treated rather than assume that all was well. Dr. Gerald Lucy, the editor of the journal Pediatrics, too offered support and a forum. When Harrison sent him letters of complaints she had received from other parents, Lucy published a paper by 10 parents of premature babies proposing a number of reforms. The message did not go unheeded. Robert Herzlinger recalled reading and discussing Robert and Peggy Stinson's account of their baby Andrew, as well as the articles by Helen Harrison. After Harrison's 1993 article proposed a number of principles for family-centered care, Herzlinger invited parents in his NICU to discuss the adoption of the recommendations. And while Duff and Campbell in their 1973 article were early advocates for parental involvement, the long list of neonatologists who advised and supported Harrison's recommendations 2 decades later indicates that clinicians across the country rallied for greater involvement of families. While NICUs are in some ways unique, they raise questions central to modern medicine. In an area of rapid innovation, where therapies quickly move from experimental to innovative, routine, and outdated, how do researchers adhere to treatment protocols and informed consent? And how do patients and family members understand and participate in clinical decision-making in a specialty where so much seems at stake and hopes are so high? I welcome any questions and suggestions. That, by the way, is my dog, who, when I practiced the talk, just looked and barked at me the entire time.
All right. Hello. All right, everybody. I'm going to come around with a microphone. If we could talk into the microphone so the people at home can hear you. If anybody has any questions for Johanna.
First of all, thank you. That was absolutely fascinating, and yes, it was also quite gruesome. So the one thing that I am left thinking is really missing from all this discussion, though, is who's paying for all this? And maybe I'm just thinking about it from a modern perspective, but 15 years ago, I gave birth to a kid with respiratory distress. Yeah. A week in the hospital was $35,000. Yeah. All of these unnecessary procedures, if the parents don't even want it, who the heck is paying for this?
Yeah, so initially it's the parents who have to pay for this, right? So the Stinsons got the bill at the end of it, and a number of other parents got bills as a result of it. At some point, states, I think California is one of the first ones, and I have to apologize, I cannot answer this with the precision that I would like to yet. This is the problem of being at the beginning of a project. But at some point, states enact legislation that basically makes it mandatory for states to pay for this. And one of the results is that it, in a way, I don't want to say that it backfires. I mean, the parents no longer get the bills, but it does now mean that NICUs become moneymakers for hospitals, which they are today. They are among the biggest moneymaker for hospitals. And so there is also a financial incentive to basically care for these infants and to keep them alive, because that is how hospitals make their money. So now insurances tend to pay for it. And I think that starts at some point in the 1970s. I'm not absolutely sure. And it is state by state. And then I think at some point there's also federal legislation requiring payment.
Thank you for a great talk. I was wondering, what do adults with disabilities think about this history? And I was thinking particularly about the disability rights movement. Were they weighing in on this one way or another?
I have no clue. I have, since nobody has written about this, and I've only given 3 talks about it, and I haven't had a conversation with anybody in the disability movement about it. I don't know. If you ask me after AAHM, I might know. So I have to give a talk to the History of Medicine folks in next May, and I honestly do not know.
I guess the origin of the question was that in Ohio there was a policy about an abortion bill related to Down syndrome. And so I knew that there were people with Downs and people with families of people with Downs who were weighing in on the issue as well. And so I wondered if maybe it.
Yeah, I mean, I think in general, I would say that I suspect that the voices of people in the disability movement is going to be as complex and diverse as anywhere in the population, right? Of course, we know that especially with the melding with the anti-abortion politics and everything like that, the members of the disability community who are opposed to abortion and who are also, I think, rightfully concerned about receiving appropriate and respectful medical care, not being pushed into no care or being told that it would be better if they died, they, will probably embrace as much treatment options as possible. But the disability movement, despite the fact that especially pro-life people often try to present them as a unified group, are not unified on this. And I think the other problem is that the severely disabled adults about whom we're partly talking here are not the ones who can process and articulate what they think about it, because that is not where their cognitive abilities are. So, the son of Helen Harrison, you will not be able to ask him what he thinks about it. And so I also always think that it's really complicated to have a discussion about what the disability movement thinks, given that, yes, anti-abortion people bring all Down syndrome people who are eloquent and articulate to protests, and, they rightfully talk about their rights, but it's not a fair discussion. So, I leave it at I actually don't know, but I also think it's probably super complicated and really political.
Thank you.
Thank you. Such a great talk. I just want to add, your question about cost. And the only reason I know this is because my granddaughter was born at 28 weeks in 2021. And now, I don't know when this happened, but now anything that isn't paid by insurance, Medicaid pays for if you are born under a certain weight. It will pay everything. So, and that's true for every family. So I don't know when that happened.
I don't know when that happened either, but yeah, that is kind of what I was referring to.
My question is, now you mentioned that NICUs were, it wasn't just in the US, but around the same time in other wealthy industrialized countries, they were also developing NICUs. Do you know whether or not they had similar ethical debates? And were different kinds of decisions being made in countries that had a nationalized healthcare system?
Yeah,
were they
certainly in England, right?
So they were setting stricter limits than what was going on in the United States. They had actual boundaries.
Yeah, and so it is interesting because, so this is my friend Jackie, and we just had a long discussion over coffee. So the neonatologists at Yale who I interviewed about this, the Lorber and that Sheffield Hospital discussion, that was, of course, England. And one of the things that one of the neonatologists told me when we had this discussion about the change of policies at Yale about myelomeningocele is that he said he always had the suspicion that in England, they basically helped the infants to die. But he said we could never do that in the United States. And so the death rate was probably different in England than it was in the US. And the American experience that they expected these infants to die and they didn't die, I think was partly because his suspicion was that physicians in England dealt with it in different ways. I don't know about other countries. I just know that that was an issue in England. So I mean, and there I also suspect that individual countries' histories play a role in terms of how the medical professions deal with it, right? So in Germany, for instance, as a result of the whole legacy of the Nazi euthanasia and stuff, that never would have happened, and their policies are very different as a result of that. So, but the other thing that's really interesting is, and so far as this really is an international movement, so this first generation and also the second generation of neonatologists, they travel especially to Sweden. So there was a Karolinska Institute that had a number of really early neonatologists, where basically American neonatologists went and kind of talked about what to do and learned some of the practices and stuff. And then they went to England. Some of them went to Israel. Some of them went to France. So there is like this whole network of people who move around, and people from other parts of the world also come to the United States, and they teach each other procedures and all that. It's really interesting. So I suspect that they also have these discussions, and I haven't yet discovered them. I think I have to go to the papers of the neonatologists to find them, and right now I'm obsessed with Helen Harrison.
Yeah, I think it would be very interesting to look at wealthy countries that have national healthcare systems, because I would think that they would have much more comprehensive debates and decisions made, and not making them in the moment, but really.
Yeah, and they might also talk differently about costs. So if you talk to neonatologists today, they do talk about how much this costs and, what the implications of that are. But I think in the United States, it's mostly a theoretical debate. There is never anything that kind of comes out of it, but that might be different in other countries.
Thank you so much for your wonderful talk, and I always end with a picture of my dogs on the thank you slide, so I feel
I'm so glad.
very
I was a little
validated
self-conscious
right
about
now.
this. His name is George, by the way.
Hi, George. I have a question about whistleblowing and the baby doe rules. Yeah. So I've taught baby doe a lot, and something that always perplexes me is, how did this idea come about? It seems to me that it's rare in the history of medicine that this is a specific kind of legal mechanism for conscientious objection that occurs. Like, I can't find another example of, conscientious objections happen all the time, and disagreements happen all the time over treatment, under treatment, end of life decision making. How did this idea come about? Why is it unique to NICU? And also, if you have time, does it still exist today? Do people still access this mechanism of reporting?
Yeah, so to start at the very end, I am actually not quite sure. I think if it doesn't, do you know that, Jackie? Well, whether baby doe rules unique to the NICU still exist. Well, I know that the whistleblowing threat still exists. And so I have a friend who's a neonatologist who kind of got me into this topic. And so I can sometimes ask him the questions that you can't really ask anybody else. So when I saw him the other day, I said, when he's now retired, but he just recently retired, right? I said, when you were still practicing, were there actually times where you helped infants to die? And he said, yes. And he said that he did that other neonatologists did it at his institutions and at other institutions. And so it's not that when clinicians, I guess it is really institution by institution. There's huge differences in terms of how much parents are told, how much parents are involved in decision making, and then also how comfortable neonatologists feel basically talking about end of life and helping infants die if they decide to withdraw treatment or not to treat. But it does happen in some units. And how clinicians do that really kind of depends on the clinician. But I also think it's one of those things that are not openly discussed or written about, but people just do it in conversation with parents, and the colleagues who understand tolerate it, but it's not a discussion that is happening publicly. And the whistleblowing, okay, that's the whistleblowing part. the conscientious objection part, right? That dates back to 1973, actually, the Church Amendment, which gets passed right after legalization becomes, abortion becomes legal. The Church Amendment gets passed, and it initially basically says that if clinicians don't want to perform sterilizations or abortions, they don't have to do so. But of course, that kind of then spreads to all kinds of other medical procedures. So I think that also then begins to apply. Well, it, for instance, applies today in terms of medical aid in dying. I know that at Sloan Kettering, we talk a lot about how clinicians should deal with patients who ask for medical aid in dying. And there was huge opposition in the hospital to the fact that patients might ask for it, and there were many, not many, but there were a certain number of clinicians who were vehemently opposed. And I know that that is one service that many clinicians don't provide because, so yeah, it's there. And did I address your question?
My question was a little bit different.
Yeah,
it was a little bit
go
different.
for it.
I'm so sorry if I wasn't clear.
No,
The
it's good.
question was a bit about the way in which the Reagan administration writ into the baby doe rules the whistleblowing aspect. That was the sort of the
Mechanism
the
that they chose.
mechanism for reporting, as opposed to other sort of moments of conscientious objection where it was sort of you just take them to court. Like why was there a whistleblowing aspect specifically for this
I think
kind
because
of?
they were relying on clinicians reporting on each other. So there has always been, both there and also in terms of abortion care, you know, the whole question about when you perform an abortion, does the fetus still show signs of life, and is that then something else? Has always relied on the fact that, you know, there were, for instance, nurses who would then blow the whistle and call an 800 number. So it kind of comes from that tradition, that the only way you can make a case is if somebody who was in the room with you notices, objects, and then reports it. Otherwise, you wouldn't know. But I do remember that, you know, they literally had a sign with an 800 number that you would call that was posted in all the NICUs.
Thank you very much. I'm Allison Norris. I'm an epidemiologist, and I study abortion access. So I've been thinking about those very connections. My question, and one of the things, of course, that we see amongst abortion providers now is that when restrictive laws are passed, clinicians aren't eager to test the limits of those laws. And partially it's because some of the penalties are extreme, including felony and loss of license, and so understandably people aren't interested in finding out where the line is exactly, and it has a chilling effect, and often clinics and clinicians will fall far short of the law. But I also think it's because potentially the time we live in terms of the litigious environment around medicine. So I was struck by you talking about some of the litigious feeling responses to clinicians in the 70s and 60s. And I wondered if you could talk about whether there was this kind of underlying fear of the law in these clinical spaces and in other clinical spaces, or if we're really seeing something entirely new around a kind of clinical a reluctance amongst doctors to press up against boundaries that could get them into trouble with the law.
I think this is, I don't know this for certain, but my sense from my reading is that the fear of the law and the notion that they might get sued does not really emerge until the mid to late 1980s. And so in the 60s and 70s, there's still such enthusiasm in terms of throwing all these new therapies and technologies at these infants. And so the question of what the consequences of that are don't really emerge until the mid-1970s. It all takes a while, right? And I think some of the politicization really happens as a result of the rise of the pro-life, the anti-abortion movement under Reagan, and then the baby doe laws. I find it very funny and ironic that parents decide to use the baby doe laws for their own purposes. It doesn't work. I mean, they don't get anywhere, even when they call the 800 numbers. People at the other end of the line are totally uninterested to kind of pursue that part of child abuse as child abuse. but I find it an interesting strategy. And one of the things that I realized is that parents are actually fairly early aware of this. So already in the debate leading up to the passage of the first baby doe laws, I found letters in Helen Harrison's papers basically saying this is going to happen and we have to organize against this, and this is not good for what we're trying to do and for giving parents more of a voice.
All right, I think we have time for one more if anybody else has a question.
So, since we talked about Susan Reverby at lunch, I've been thinking about the sort of science for science sake that you brought up in the quote from the doctor saying, "I'm living in the present and thinking about the, this fantastic present moment, and then in contrast to these horrific things happening to parents thinking about the future." So this is, as we were coming to terms with Tuskegee and thinking about the justification for that being science for science sake, when does that sort of, do you have a sense, in terms of the end of your story, do you have a sense of when that, like, this is the fabulous present that then one doctor you quote, that sort of mentality kind of dissipates amongst this?
I think it happens slowly and it happens piece by piece. So William Silverman, who I was quoting there, right? He is actually one of the very first people who starts advocating among pediatricians and neonatologists for actually testing therapies and for seeing whether the therapies and medications and whatever that they're applying really work. And he makes himself very unpopular in the field as a result, or I would say the field really splits. There are the adherents to William Silverman, and then they're the ones who are very critical. He becomes very close friends with Helen Harrison, which I find really heartening. They write each other these tiny little notes, cheering each other on and sending articles back and forth. And he eventually moves to the West Coast, and they have each other over for dinner, and she introduces him to all kinds of people who are in the parent advocacy movement. So it also then, another part begins to change when parents begin to form this parent advocacy movement. And as a result of that 1993 article that Helen Harrison writes that proposes the 10 reforms, a lot of NICUs say that they're moving towards more parent-involved care, but when I talked to a couple parents who were having premature infants in the early 2000s, it turns out that they might say that they're doing this, but NICUs really have to change their architecture in order for this to happen. And so I think it takes the rebuilding of hospitals and of neonatal intensive care units to move away from these large spaces that I showed earlier to places where there is actually some privacy and where people have private rooms or semi-private rooms so that you can have a discussion with the clinicians without everybody overhearing you, and also the ability to, basically nurse your infant and they're really into kangaroo care at some point, be comfortable being naked and putting the naked infant on you. All these things take decades. And they don't all happen at the same time. So I think it's a really slow change. And I do have to say, from stories that I hear about today, including stories that Jackie told me and other people, I think there's also still many things that have remained the same. And among them are, for instance, the fact that parents do not get fully informed consent, that basically clinicians asked for assent for a little part of what is happening, and otherwise they still forge ahead without ever really explaining what the options are and what the consequences are of all these different options. I don't think that is particular to neonatal intensive care unit. I find that, for instance, the oncology, especially children's oncology, is like that as well. I have heard other PFAC members who had children who had cancer talk about the fact that they were never informed about the long-term impact of these treatments or those treatments. And in cancer care too, right? It was also all things where people so much place their hope on a new therapy, and where the line between therapy and experiment is not always clear. And so, yes, things change, but they don't change uniformly, and it's kind of a patchwork.
Thank you so much, everybody, for coming to the Burnham Lecture.
Thank
Give
you
a round
so,
of
so
applause
much.
for Johanna. Thank you so much for taking the time to be with us, Professor Schoen.